Hi, welcome back. For those who are seeing this video for the first time and who haven't seen my previous videos, I would like to introduce myself. I am Rocha. I have done my doctorate in nursing with psychiatric nursing specialty. Please do subscribe and share these videos. I am doing these videos with an intention that they would be of some help and they would provide valuable information for you to do well in your studies. Let's not waste time. Straight away, we will just move on to the topic. So, today I am going to deal with mood disorders. Mood disorders, before we could proceed, I would like to introduce this topic. They come under affective psychosis. So, previous class we have seen about functional psychosis, that is schizophrenia and subtypes of schizophrenia and other psychotic conditions we have seen. And here, mood disorders come under affective psychosis. Now, when we say mood, how do we define mood? Mood is defined as an effect which is sustained for a prolonged period. Mood is an emotion which stays for a longer time. So, what is meant by affect? So, when we say feeling, happiness, sadness, it just comes and goes. So, when an effect is sustained for a prolonged period, we call it as a mood. Now, let me put it in another way. What is mood? So, when we look at ocean, it is stable. In the middle of ocean, it is just stable. If we consider that ocean as a mood, at the seashore, waves do come and touch the seashore and go back. So sometimes high waves, sometimes low waves, they just come and touch seashore and goes back. So the waves are considered as effect. And these effects, like which stays for a period, a stable period, or sustained for a period of time, we call it as mood. I hope you got a clarity regarding what is affect and mood. Affect is temporary and mood is almost like a permanent, which it stays for a long time. Now, under mood disorders, we have two types of major classifications: mania and depression. So, in this video, we are going to see about mania, and coming videos we will discuss about other conditions like BPAD, bipolar affective disorder. So, we'll just move on with mania. Now, coming to mania, before that we just see, as mentioned, I'm going to discuss about mood disorder, the classification, maniac episode, classification, etiology, psychopathology, clinical features, diagnosis and treatment modalities, nursing aspects we will see later in another part of a video. Mood disorders are group of clinical conditions like mania and depression characterized by loss of that sense of control. Psychomotor activity is increased or psychomotor activity is decreased. Then there is subjective experience of great distress in the person. Now, coming to mood disorders, how can we classify them? Before we could classify them, I would like to tell you an illustration. If you take this straight line and draw a line here, these two are poles. One pole and the other side, the other pole. So one pole, if you say mania, that is excited. Other pole is depression, low mood. In depression, we have low mood. Now, what is normal mood? Normal mood, we call it as euthymia. Euthymia. Normal mood is called as what? Euthymia. If this euthymia, if a person is excited, has a sense of well-being, then he moves up to a condition called as hypomania. It's hypomania, we call it as stage 1 hypomania. And if a person is suffering with a mild sort of low mood and depressive features, we say he is suffering. And if these clinical features of low mood, lack of interest in life, we call it as dysthymia. We call it as what? Dysthymia. And from dysthymia, person can land up into depression, and under depression we have mild depression, moderate depression, and we have severe depression. If a person moves from dysthymia to hypomania, or between dysthymia to hypomania, and he shifts from here to here, we say he is suffering with the cyclothymia, where there is an instability in moods. One day the person might be happy, the other 2 3 days the person might be unhappy. So we call it as cyclothymic. So we have another condition called as a bipolar affective disorder, BPAD. If a person suffers with the depression at one episode and after taking treatment lands up into mania in the next episode and takes a treatment and lands up either into hypothymia or dysthymia or depression, so his condition is altering between these, and we call bipolar affective disorder. I hope you're clear. So we have euthymia, hypothymia, hypomania and mania. We have dysthymia, depression, a person fluctuating between these two. We call them as cyclothymics. And person fluctuating between mania and depression, we call them as suffering with bipolar affective disorder. So whatever the person is presenting with in the current episode, we call it as depressive episode or maniac episode. Recurrent depressive episode or disorder we call when a person repeatedly has an attack of depression. And persistent mood disorder, one thing or the other, unspecified mood disorders, where we know that there is no appropriate cause for it, or sometimes person can land up into mood disorders if they are suffering with chronic health conditions. Maybe person suffering with arthritis for a prolonged period can land up into mild depression. So such type also we can call them as other mood disorders or mood disorders unspecified. Obviously, when there is no absolute cause, when the cause is not identified, we mention as unspecified. Now coming to mania. Mania is defined as a condition with a distinct period of abnormality and persistently elevated, expansive, irritable mood for lasting for at least 1 week. Remember this, we will try to repeat this one. Distinct period of abnormality and persistently elevated, expansive, or irritable mood which lasts for 1 week or less. When we say less, that means the signs and symptoms are too high where a person needs to be hospitalized. Coming to the lifetime risk of a person, it is between 0.8% to 1%, and each episode usually lasts between 3 to 4 months. Coming to classification of mania, it's easy now. Maniac episode, hypomania, mania with psychotic symptoms. When we say psychotic symptoms, presence of what? Hallucinations, and next one, delusions. We call them as psychotic symptoms, delusions. Now without psychotic symptoms, with the psychotic symptoms, presence of hallucinations and delusions, other maniac episodes and maniac episode unspecified. Now coming to etiological factors, neurotransmitters. We know neurotransmitters cause psychiatric disorders, alteration in them. So it's a general understanding that when we are anxious, usually what system gets activated? Sympathetic and parasympathetic nervous system. Or we call it as adrenergics, epinephrine, norepinephrine, adrenaline, noradrenaline. Here in mania, we find increased levels of norepinephrine. Then we have abnormality in dopamine and imbalance between cholinergic and adrenergic systems. Decreased serotonin levels. Serotonin levels are decreased. Now, coming to structural abnormalities. How can we identify structural abnormalities? When we do CT scans, MRIs, contrasts, and PETs, etc., they have showed that lesions are present in right hemisphere or bilateral subcortical as well as periventricular gray matter. Coming to genetic considerations now, in previous schizophrenia also we said higher instances in monozygotic twins. Close relatives, higher instances when compared to that of general population. Now, families where cyclothymic characteristics run or cyclothymic personalities are present, more chances of these family members from that person landing up into mania. I hope you are able to get me. First degree relatives 5 to 10%, identical twins 40 to 7% of chances. Next, coming to psychodynamic theories. When you say psychodynamic theories, who has given psychodynamic theories? You have to remember Sigmund Freud is the one person who has explained about psychodynamic theories or psychoanalytic theories. According to him, he says faulty family dynamics during early life. When we say faulty family dynamics, maybe divorced parents or single parent, traumatic developmental stage, traumatic childhood, faulty family interactions, or sometimes double blind communications. So sometimes child abuses, etc. Whatever you can consider faulty family dynamics do cause person to land up into mania later stages. Now another way he has put is depression. When it is denied, person can land up into mania. Maybe loss of some valued object or loss of valued person who can lead a person to mania because they deny landing up into depression. Next one, coming to psychopathology of mania, we see lack of inhibition. When we say inhibition, not able to control the emotion, we call it as lack of inhibition. Then apparent quickness, tendency to react overly. Okay, distractibility is present in this person. Flight of ideas, moving from one context to another, one topic to another, swift thought flow, elation of mood accompanied by a sense of well-being and lack of insight in this person. Not only this, judgment is poor, insight is absent, already mentioned here, attention and concentration is disturbed. So according to Abraham, he said inability to tolerate developmental tragedy, as I have already mentioned, like loss of parent, divorced parents. Then Klein said it's a defensive reaction to depression. Actually, a person who keeps smiling and who is in a maniac condition doesn't mean that he is really psychologically well and he is very happy and all, but in of hearts he is very sad. Then we have another stress vulnerability model which says that a person who is exposed to frequent stress for a period of time also can land up into mania. According to transaction model, it says it's not appropriately one factor which causes, but it says that the mania can be caused because of biological factor, neurological factors, psychological factors, and stress. When all these come together, maybe the person can land up into mania. So these are all some of the psychopathology of factors which can cause mania and the psychopathology of mania. Now, coming to clinical features, we are going to see in detail. As we have seen earlier also, we said these symptoms should be present for 1 week: irritable, elevated, expansive mood. And psychomotor activity is increased, restlessness to maniac excitement. We have speech and thought disturbances, other features, and goal directed activity. Absence of underlying organic cause. So, if there is an organic cause, then how do we categorize it? We need to treat that organic cause, and once we treat this organic cause, definitely the person will recover and maniac symptoms, maniac features will reduce, and there is a disruption in social as well as occupational functioning. Next, we will see about elevated mood, which passes through 4 stages. First one is euphoria, mild elevation of mood, that is increased sense of psychological well-being or happiness. That is hypomanic stage, which will lead to next stage, that is moderate elevation of mood, that we call it as elation. Here the person has a feeling of confidence, enjoyment, and increased psychomotor activity is present. The next stage is severe mania, that is stage 3. Person has exaltation, lands up into that stage of exaltation, next leading to ecstasy. It is also stupor stage of stage mania. We said euphoria, elation, exaltation, and ecstasy. So here we have a sense of blissfulness where the person is happy always, irrespective of the condition. We can see smile on that person's face. Next, we have in detail about speech and thought disorders: more talkative, racy thoughts, and pressure of speech, playful language. They speak loudly, flight of ideas. So when we are excited, usually our voice or our tone increases. The same way you can see here, they talk very loudly, move from one area to another. Delusions of grandeur, mania with the psychotic symptoms. Delusions of grandiosity is present sometimes. When we say grandiosity, self boast. They think that they are PM or CM, or they can do anything, Karorpati, Superman, Spider-Man, or they feel that they have lot of powers in them. So they believe like that and they take or do some risky activities. Then delusions of persecution and hallucinations. These last 3 we can say mania with psychotic symptoms. Next, we have mania features where we can see excessive planning in them, increased sociability or social interactions. Even though they don't know the people, they just go and they just wish them and talk to them there because they are excited. And poor judgment, they won't be able to assess whether they can do the things or not. Reckless driving, giving money to strangers, and dressing style also is gaudy, like no red and uh, green colors, odd colors, attractive colors, flamboyant clothes, different types which attract persons. Then other features, because their mind is excited, psychomotor activities increased, they cannot sleep because it is restless. Appetite is increased because their activity levels are increased, but they cannot eat. Because they cannot sit still in one place. And insight is absent. We said delusions, hallucinations, these features are present in these persons. Next, coming to hypomania, as already seen, first stage from euthymia, we go to euphoria. That is the stage 1 of mania, ability to function much better and marked increase in productivity and creativity. And some of the signs of hypomania are similar to that of mania. Activity levels are increased, self-esteem increased, flight of ideas, easily distractible, sense of well-being, they are happy, irritable, sometimes aggressive. They cannot stay still for a quite period, long period, rapid speech, less sleep, and high sexual drive is seen in these persons. Now, coming to diagnosis, we have young mania rating scale. By using this rating scale, we can diagnose a person. We have ICD classification, and we have seen lots of clinical features. Based on the signs and symptoms present, we can diagnose the person if he is suffering with mania or not. Then, according to DSM 5, already discussed, the same thing is mentioned here: distinct period of abnormality, persistently elevated, expansive, irritable mood with increased goal directed activity, energy lasting for at least 1 week, and present almost every day and nearly most of the day. And apart from that, at least three of the following symptoms should be present, that is, increased self esteem and grandiosity, decreased need for sleep, more talkative, pressure, flight of ideas, racy thoughts, distractibility, and goal directed activity. And we said excessive involvement in activities which are potentially harmful for the person, reckless driving. Now, coming to treatment modalities, first pharmacology, we have lithium, carbamazepine, and sodium. Apart from that, alternatively, we can give this. But what is most important is lithium. And when we give lithium, we have to observe for lithium toxicity, because lithium has the ability to replace sodium. And the person who takes lithium, usually sodium depletion occurs. And when lithium sits in place of sodium, it causes nephrotoxicity. Um, Nephrotoxicity is one thing, neuro problems, peripheral neuropathies, muscle spasm, tremors, then arrhythmias, cardiac arrhythmias, and renal functioning is altered, and liver functioning is altered if there is increased doses. So you have to be very careful with the lithium when you're giving. Blood plasma levels need to be checked for any toxicity levels. Then alternatively, if a person is not responding for pharmacotherapy, then preferably ECT is given for that person. And coming to psychosocial treatment, we said faulty family dynamics can lead to mania. So we have to assess as if the person needs family therapy or marital therapy. So these are certain treatment modalities. Now, just for a recap, we have discussed about mood disorders, what is mood and affect, discussed about mania and bipolar affective disorder, or depressive episode, mania with psychotic symptoms, without psychotic symptoms, and unspecified. We have discussed about etiological factors, which says neurotransmitters, alteration in levels of dopamine and serotonin, and decreased levels of norepinephrine, structural abnormalities, which says lesions are present in a periventricular region and hemispheres of brain. We have seen about genetic factors, monozygotic or cyclothymic personalities existing in families. And apart from that, we have discussed about several clinical features, how to identify a person with mania, and the diagnostic criteria. We said ICD, DSM 5, based upon signs and symptoms, and also Young Mania's rating scale. Coming to pharmacotherapy, lithium, carbamazepine, and sodium bicarbonate is very important. These three drugs, any according to the preferable choice, they are prescribed. And calcium channel blockers or beta blockers, like atenolol, propranolol, etc., they reduce the anxiety in the person. So apart from that, ECT and psychosocial treatment. So I hope you have understood. I know we have gone through quickly. Now then, in our next video, we'll see about the other mood disorders, and we'll see about the nursing management of mood disorders in detail. Thank you all very much. See you soon. Please don't forget to subscribe this channel and share with others. Thank you.